Inspirated flow rate 60 to 80 liter per minute, peak 0 to 5 centimeter water, FiO2 titrate to keep SpO2 more than 90%. Now the additional consideration in mechanical ventilation. Post-intubation hypotension, common in severe acute asthma because of application of positive pressure throughout the respiratory cycle in patients with pre-existing dynamic hyperinflation and IP, hypovolemic sedation. Should be managed with liberal intravenous fluid and appropriate ventilator strategies. With close monitoring of SpO2, patient can be disconnected from the ventilator circuit to allow adequate exhalation of trapped gas and decrease intrathoracic pressure. Neuromuscular blockage should be considered in patients who demonstrate considerable patient ventilator dysynchrony despite adequate sedation and analgesia. It is important that blocking agent should be given in intermittent boluses. Administration as continuous infusion should be avoided because of increased risk of myopathy associated with concurrent corticosteroid use. So, now the conclusion. Goal of management of severe acute asthma in ICU is to unload the respiratory muscles, correct hypovolemia, provide adequate ventilation, and minimize lung injury while treating the underlying airway inflammation and bronchoconstriction. Adequate expertise and appropriate ventilator strategies are a prerequisite in successful treatment of severe acute asthma in ICU setup. Thank you all for patient hearing.
Just have come from the seat of audience. I know the pulse of audience, so I will make a very, very short story. Nothing to be worried. Thank you. Before going to the subject proper, the management of COPD with type 2 respiratory failure, I think we should know something about what COPD actually is, what is type 2 respiratory failure, what is the contribution of COPD on respiratory failure, and then the management. As we know about COPD, internationally accepted definition, the chronic obstructive pulmonary disease is a disease state characterized by airflow limitation that is not fully reversible. The airflow limitation is usually both progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. If we enter into the depth of the definition, we can say chronic obstructive pulmonary disease refers to chronic bronchitis and emphysema, a pair of disease in which the airways become narrowed, which leads to limitation of airflow to and from the lungs and generally presented with shortness of breath. In contrast to asthma, limitation is poorly reversible and usually gets progressively worse over time. Some of our colleagues in several times in several parts of the world calls this disease as chronic obstructive lung disease, that is called COLD, chronic obstructive airway disease COAD, chronic airflow limitation CL or CAL, chronic obstructive respiratory disease CORD. These are the, I think, nicknames of COPD. If we go to a short history of the disease, COPD always existed but in different names. In 1679, Bonnet described it as voluminous lungs. In 1769, Morgagni described as tardic lung, etc., etc. For the sake of time, I will come to the latest history. The term chronic bronchitis and emphysema were formally defined by at SIBA Guest Symposium of Physicians in 1959. And finally, the term COPD, which is most popular today, was first used by William Biscoe in 1965. It is the today's most preferred name, exceeding all other nicknames of the disease. A few words about COPD. COPD is the fourth leading cause of death in the United States, first being heart disease, then cancer, and third cerebrovascular diseases. In 2000 AD, the World Health Organization estimated 2.74 million deaths worldwide from COPD. And interesting thing is that in 1990, COPD was ranked 12th as a burden of diseases, but by 2020, it is projected to be ranked 5th. Now we are shortly coming to the disease. What are the risk factors? There are two factors actually, which is known as host factor and exposure. Host factor consists of genes, that is alpha antitrypsin deficiency, then hyperresponsiveness of the lung tissue and lung growth. And you all know better, exposure to tobacco and tobacco smoke, occupational dust and chemicals, infections and socio-economic conditions also risk factor for this disease. In short, the pathogenesis of disease consists of these noxious agents, what I told, tobacco smoke, pollutant, occupational agents, etc., along with the genetic factors what I described earlier, together causes COPD or great enemy. If we go a bit detailed to the pathogenesis, these noxious particles along with the host factors creates inflammation in the lung. This inflammation causes release of proteinases in one way and oxidative stress in another way. These two stress and engine causes COPD pathology. In more description, inflammation that is produced in the lung tissue, in one way it destroys the parenchyma of the lung, it loss of alveolar attachment and decrease of elastic recoil. On the other way, small airway disease, airway inflammation and airway remodeling. From the both ways, airflow limitation occurs.
Excuse me, Dr. Rana, I draw your attention. The topic is management of COPD with respiratory failure.
Yes, sir.
You only have 10 minutes. You're wasting your time. So go to the point, please. Appreciate it.
Okay. This is the. I was actually possibly I was able to make the everything in time. Anyway, this is the key point of my full lecture. As in cancer therapy (TNM), in 2003, it has been staged. COPD has been staged in 0, 1, 2, 3, and 4 stages. According to risk, the patients that are in risk but not in patient showing the symptoms like chronic symptoms, exposure to risk factors, etc. In that cases only we can avoid the risk of factors, influenza vaccination, etc. is enough for the treatment. In mild cases, that is number 1. That is also the you can add just short-acting bronchodilator when needed. And you see, in moderate, severe, and in very severe, we are actually involved with the inhaled glucocorticoid in the severe cases, and we will think about the oxygenation. How respiratory failure occurs in this COPD, that is the definition, is inadequate gas exchange due to pulmonary or non-pulmonary causes leading to hypoxemia, hypercarbia or both, documented by PaCO2 more than 50 mm of mercury or PaO2 50 to 60. From all the causes, COPD is the most vital causes. That is why we have thought of these things. Mechanical ventilation for acute. First we are considering the drug, and finally we are going to the intubation, conventional, mechanical or non-invasive. Respiratory failure intervention, supportive therapy and specific therapy.